Today I am presenting my pathology case. Today's date is 6/30, June 30th. Exam to be presented is a 3-view knee. Image modality is X-ray. The date of the exam was 6/24. The reason for the request was pain. Projections are the AP, oblique, and lateral knee. Patient age and gender, she is a female, 65 years old, and she was in a wheelchair. Pathology and the diagnosis is severe osteopenia, knee joint effusion, chondrocalcinosis, and vascular calcification. So I'm going to start by the pathology, the severe osteopenia. It is the loss of bone mass. Bones become weaker and the inside of bones become brittle. It occurs usually after the age of 50, and women are more prone because they have a lower bone mass than men. Some people are genetically prone to the condition if there is a family history. Diet, exercise, and some medications can keep bones dense even in the onset of osteopenia. Osteopenia can lead to osteoporosis. About 18 million Americans have osteopenia. It usually has no symptoms. Bone loss does not cause pain usually. I believe this patient had pain because of the other factors, the vascular calcification and the knee joint effusion. So as people age, the body does not make new bone as quickly as it breaks the old bone down. The National Osteoporosis Foundation recommends to have the bone mass density checked. If these are the reasons: if you're a woman 65 years or older, postmenopausal women younger than 65 with the risk factors that they list, and postmenopausal women that they break a bone when they're doing a normal task. It just breaks easily. So they should get tested. The test that they perform is a DEXA scan, the dual energy X-ray absorptiometry. It measures bone density. The test uses low energy X-rays and compares the density of the patient's bone to a 30-year-old of the same age and race. The treatment for osteopenia involves diet and exercise, and taking calcium and vitamin D might be recommended by their doctor. Avoiding foods that promote bone loss, like really salty food, will promote that. It's not good. And alcohol, a lot of alcohol consumption and smoking may be talked about and addressed. So onto my images. I'm starting with the AP. The digital detector was used, a 16x16 with the grid in the table buggy. The technique was 40 inches SID. I can't exactly remember the technique. I'm going to say a 68 at 5. I will double check, or you let me know if that's completely wrong. So image exposure for this AP. There is proper brightness to see trabecular markings and soft tissues. Bone loss is present. The bone is more radiolucent and it will attenuate the X-ray beam less. The image appears darker. I believe that the technique could have been reduced. The image is still diagnostic quality. The patient laid flat on the X-ray table. The CR was angled perpendicular to the apex of the patella. There is slight rotation indicated by the lateral aspect of the patella. It should be in the middle. The patient was in a lot of pain. In her back, an extra blanket was placed to support her. The anatomy seen is the patella right here, the femur. The lateral epicondyle is here. The intercondyle eminence is right here. And the head of the fibula and the tibia. Okay. Next image is the oblique. Okay, the oblique. A curved sponge was used under the patient in the right hip to move her knee into a 45-degree angle. The CR was perpendicular to the apex of the patella. A right marker was placed in the upper right-hand corner. The patient was in pain, but she was able to hold the position for the exposure. The leg, I believe her leg should have been more medially rotated to open the tibio-fibular joint right here. This should be open. It's not. It did still pass as diagnostic quality. So the stuff seen, have the patella right here. Have the medial femoral condyle. It's here. The medial plateau is right here. Lateral tibial condyle. The fibula and tibia. Moving on. Okay, the lateral. Okay, so the patient was able to, she frog-legged her leg out and into the lateral position. The image is in a true lateral, as you can tell by the femoral condyles. They're superimposed. I think I should have, or I know, I should have, she's in a 90-degree flexion. It only calls for about 20 to 30-degree flexion, so she definitely, I should have had her bring her leg down more, and it would have opened this, what is that called, the patellofemoral joint. So what we see on this, and again on all of these, the technique possibly could have been reduced because she does have a lot of bone loss and all this darkening areas all of here could have reduced it. So we have the femur right here, the femoral condyles there, superimposed. The tibial plateau is right here, and the tibia and the fibula is back there. All right, thank you.